Hello, 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 Facebook Nation. This is Dr. Maurice Scholes, the chair of the Social Media and Branding Committee for your National Medical Association. Proud to bring you the June edition of NMA Talks. This month, we're going to focus on men's health, and a topic near and dear to all of us in men's health is PTSD, or post-traumatic stress disorder. And we've got a fantastic panel of experts to talk about what PTSD means, how it presents itself in the Black community, what we can do to solve it, and what we can do to support those that we love that are suffering from it. And if you have something related to PTSD, maybe you'll get a little bit nugget too. So with that, I'd like to remind each and every one of you to consider signing up and registering for the National Medical Association Convention and Scientific Assembly. It's virtual again this year. It starts on Saturday, July 17th and goes through July 21st. And we will have lots of speakers, lots of activities, and lots of way to getting continuing medical education. So I look forward to seeing each and every one of you in the sound of my voice there. Don't meet me there, beat me there. And with that, I'd like to introduce my first guest, Dr. Arnold James. Dr. James is a psychologist based in New Orleans, Louisiana. He has many decades of experience working at the VA hospital system with veterans that served our country proudly and came back with some scars that you can't always see. Secondly, Dr. James has a private practice. And with that, I'll let Dr. James introduce himself and say hello to our Facebook community on this NMA Talks about PTSD. Dr. James, hello.
Well, good evening or afternoon, wherever we are, or morning, wherever we show up on virtual, on the web. Yeah, I am Dr. Arnold James. I've been in New Orleans for right at 30 years doing this work of helping people with their mental health and also just trying to help people live the best lives that they can possibly live. Dr. Scholes is correct. I work at the VA hospital in home-based primary care with veterans. I also have a private practice, and latest accomplishment has joined Dr. Scholes and a couple of other professionals in town to become clinical scholar fellows with the Robert Wood Johnson Foundation on the last of their cohorts for the next couple of years.
All right. So, Dr. James, your website is there below us. If you all want to follow and reach out to him, there's a nice way to do that. So let's get things started, Dr. James. And how about let's start with definitions. What exactly is PTSD and how you define that to a layperson?
Okay. PTSD by diagnostic standards are different than the way that people think about PTSD. The history of the term was started right after World War II when people came back from the war with these feelings of dreams, nightmares, hyperstartle, alertness. And what is this syndrome that these people are coming back with? Started to look at it, they called it shell shock. Even up until the Vietnam War, people would have this reaction to war, and we would consider that this still people are shell shocked. I think it was like in the early 70s that the psychological community got together, looked at how these symptoms came together, and started to call this post-traumatic stress disorder. According to the symptomatology of post-traumatic stress disorder, of having been exposed to a trauma, either personally or vicariously, that is a threaten your death or some loved one. If you have that trauma, you can pinpoint it to a trauma. That trauma is then relived through dreams. There's a sense of an avoidance of the traumatic experience. There's hypervigilance, there's insomnia, there's appetite disturbance, there's dysregulation of emotion. A lot of these things were what we think of as PTSD. Right after that, people start to look at, well, what about a victim of or survivor of sexual violence, rape? The same kind of traumatic experience that is of and beyond that which you would normally experience in your day-to-day life constitutes the event. How that event plays itself out in the community, especially for those of us who do the diagnosing, there are about 8 criteria that we look at. This is the conundrum for people, particularly African Americans.
Very good. With that, Dr. James, let me bring somebody else into the conversation, because there's
ahead.
a lot more to say there. And I want to make sure we have a little bit of back and forth. Dr. Stephen Fisher, who is the chair of the Aerospace and Military section of our National Medical Association and a 20+ year military veteran. Thank you for your service, Dr. Fisher. Is going to come in and talk to us a little bit about this, not just as a physician, but also as a service member and as a Black man, really trying to make medicine and patients we serve better. So, Dr. Fisher, kudos to you, your service, the fact that you speak multiple languages, and so you know about PTSD not just in plain speak English, but in all kinds of other languages. Dr. Fisher, please say hello to the crowd.
Yes, thank you. Thank you for having me. As Dr. James had mentioned, the military has been dealing with this from the beginning. And after World War II, the military at Walter Reed Army Institute of Research and Walter Reed Army Medical Center had established the Forest Glen Annex in Silver Spring, Maryland, as an overflow facility for rest and rehabilitation of people that we would today regard as suffering from polytrauma. And it is there during the war years and the interwar years and post World War II, throughout the Korean War and the Vietnam War, up to this day, that a lot of military medical research in PTSD and polytrauma has occurred. So yes, as was mentioned, we had different words for it in the 1800s and the early 1900s. The spectrum of combat stress to shell shock, and it was recognized that people needed time to overcome invisible wounds as well as the physical wounds from war. Over the last 20 years, the Department of Defense and Veterans Health System has made great strides in providing clinical practice guidelines for primary care providers to diagnose acute stress disorders and post-traumatic stress disorder early for early intervention, as well as what we would call mental health first aid, the sort of self-aid and buddy aid that active duty members and veterans in the community can provide. There was a RAND Corporation publication on behalf of the government in 2006 that addressed the stigma as a barrier for active duty service members and veterans for receiving care. And since then, since that 2006 report, the Department of Defense changed its policies, not allowing these diagnoses to
Thank you very much
encumber the careers of service members.
I'm sorry to interrupt, but I want to make sure we get a chance to get our other two guests in so we can keep the conversation going. Again, thank you, Dr. Fisher, those kind words. I want to have Dr. William Lawson added to the conversation. Dr. Lawson is the chair of the psychiatry section, professor emeritus at Howard University, and the medical director of addiction services and behavioral health of Montgomery County, just outside of Washington, D.C. in Maryland. He's also affiliated with Emerson Research Institute. Dr. Lawson, please say hello to the public here on Facebook Live, and say why you answered the call and say yes to talk about PTSD for Mental Health Month. Dr. Lawson.
Yeah, I really appreciate the opportunity to speak to this audience and to address this very, very important topic, post-traumatic stress disorder. And we talk about mental disorders being developing from experiences in terms of the environment. But PTSD is a known disorder that's a direct result of specific events in the environment. Sure, there may be genetic components and others, but the key point is that PTSD is expressed by the experience. I've worked in two settings. One is I used to be chief of services at Rutherford VA in Indianapolis, where I had a chance to talk to a number of combat veterans. And also, after that, involved in academic centers in which I involved with clinical trials trying to find treatments for PTSD, and also recognizing that there are features of it that occurs In outside of the veteran population is very simple. The important thing to recognize is PTSD is more common outside of the military. That many of the features, such as persistence, is very real. That it results in actual brain changes that help to define the experience and make it so difficult to treat that it can often become a lifetime illness if we do not recognize the importance of early intervention to be involved in treatments that can have some lasting impact. So PTSD is extremely common.
Thank you, Dr. Lawson. I appreciate you joining us. And I think you make an excellent point that although a lot of people may associate PTSD with military, and Dr. James and Dr. Fisher have spoken about how it impacts and presents itself in that setting, it's also very common in the lay population because this isn't something unique to or only caused by military-based trauma. The last member of our panel we're going to bring is Dr. Ron Bailey, and he might be the last person I'm introducing, but by no means is Dr. Bailey our least. In that, number one, he's a past president of our National Medical Association. Number two, he's an active member of our psychiatry section. And number three, he'll be joining Dr. James and I in New Orleans as the incoming department head of psychiatry at Louisiana State University. So first and foremost, Dr. Bailey, welcome to New Orleans. Second, it's wonderful to have you here. And at some point, I also want to make some time to talk about your book, At Gunpoint. So Dr. Bailey, say hello to the crowd and let them know you're here.
Hello, and thank you very much. Similar to Bill Lawson, I thank you very much for putting this group together. Really, I think an important topic, one that very often I think gets overlooked. African Americans often, because of discrimination, because of bias, and because of a lack of many of the skills we need to develop resilience, struggle with PTSD concerns longer than other groups and are much more adversely impacted in a negative way that adversely affects their quality of life. There's some recent studies, I think, showing that there's less speaking and talking about a death, for example, and issues of bereavement in Black groups and other settings. These are some strategies and some data we should be aware of because it can actually lead to strategies we can implement to help improve the quality of lives of persons who've had a variety of stressors. I'd also add, you make the point about New Orleans. I actually just got here, been here 2 weeks, but wanted us to be from New Orleans to about the issue of Katrina. And Katrina's really a metaphor for me now. Been involved in violence, mentioned gun violence like throughout the entirety of my career. The reality is, for a lot of reasons, not just Hurricane Katrina and other stressors, if you will, substantial stressors, Africans very often have a greater degree of difficulty because of the stresses they experience, and we need better strategies to help them come out of that in a more effective way. So thank you for having me tonight.
Excellent, excellent. So with the panel here, we've heard from Dr. James, Dr. Lawson, and Dr. Bailey talking about PTSD as an issue. Now let's drill down on Black men specifically. Dr. James, how have you identified PTSD in somebody that didn't come to you for that as a problem and didn't realize that was part of their issue?
As I was alluding to earlier, that is the conundrum that we find ourselves in. If you follow the DSM manual of diagnosing PTSD, there are specific criteria that a person has to be met. There are 8 criteria. There are 2 of one, 3 of another. 3 have to be there. If the other ones aren't there, there's some things. But when people come into your office that have dealt with life issues, it may look like PTSD, but as a clinician, you've got to be savvy enough to look at what is the constellation of what they are coming here for that may not fit the criteria of PTSD, but indeed there is a defined trauma. What else can you use if you've got to be able to document and bill for a particular reason for why your treatment and coming up with a treatment plan, but to look at trauma, everyday trauma in a different way, how it manifests itself, that a person may not say, I have PTSD. They may come in with eating disorder, erectile dysfunction disorder, something else. But as you drill down into that symptoms, it may be there is a trauma. Now let's talk about the trauma. It may not fit the diagnostic criteria. It does not mean it needs to be ignored when you look at how you're going to treat somebody and improve their quality of life.
Excellent point. Dr. Fisher, you have a strong background in occupational health. So in someone at their job, how would this come out as part of their job performance, or somebody that you're working with that didn't necessarily come to you on their own, but they came across you because of something else that popped up?
Oh yeah, that's Maurice. That is an excellent point. So, from an occupational health perspective, people who work in safety-sensitive positions, if they power wash the side of a building and have to climb scaffolding, and they may be reminded of something while they may be in a dangerous position, they may react or have an accident. And so I want to know, as an occupational health physician who is medically clearing people to do dangerous jobs, if they're in right mind to do those jobs. Sometimes when I'm working with security personnel and law enforcement, I do have to issue a weapons restriction until I know that they're well controlled on psychotropic medication. Getting a note from their treating psychiatrist or clinical psychologist. In occupational health, it's really a focus on what they do for understanding. The provider should understand what they do for a living and recognize that they work in safety-sensitive positions and where the diagnosis may interfere with their safety or in the safety of others.
Excellent. Dr. Lawson, in talking about your arc of experience, you really have a very wonderful focus, not just on a specific institution, but community. So we've talked about PTSD and how it manifests as someone comes into Dr. James's private practice, or if they come across their employer operated doctor through Dr. Fisher. How does this manifest itself in a community situation or a community environment?
Yeah, look at it, first of all, as PTSD can occur in any age group. What we tend to forget is that many of our young people are exposed to violence and danger. So when we look at young people who present supposedly with attentional deficit disorder, sometimes with disobedience, you find that a key action has been that they've been victimized in the community, abused, or as I just had a patient who was sitting in the car and a gangbanger came walking by, shot his best friend while he was sitting in the car. It can also strike young adults. And one of the areas is right now we're exposed to a pandemic, COVID, in which there's the psychological effect of recognizing this is a potentially lethal illness. But I've just had a patient who came out of 2 months sitting in a ventilator, dealing with the COVID symptoms. And then we have to look at the experience of many of our elderly people who see themselves as trapped in adverse circumstances, who are more likely to be abused than anyone else. So the presentation can vary because we do not think PTSD, but we need to think PTSD when people think present with other kinds of symptoms.
Excellent, excellent. Dr. Bailey, what do you have to add?
Well, I think that Dr. Austin's points are timely. The reality is, all of us on a regular basis are exposed to patients with increasing levels, of high risk, more violence. The pandemic is a very good example. I think your point earlier that I've written books now on gun violence and on domestic violence, which came out last year. Both, I think, taught me substantial lessons in the amount of high risk violence many persons, I think, in our community are exposed to. I think the issue of how children are exposed very early is also very important, because often if you're exposed very early as a child, you learn certain methods of how you're going to respond, and some of those are actually maladaptive, and they actually worsen and prolong the likelihood of any kind of clinical improvement, and even in some regards, lessen our attempts, I think, at intervention. A huge issue for me very often are African-American males. As an African male physician, I've spent much of my career very often having referrals to me by young individuals in this setting, adolescents who very often have been traumatized in a variety of ways, some emotional, but very often physical and sometimes even sexual. And the fact that very often they are misunderstood, that they're thought to not talk at all. My experience has often been, I'll get into a room with a young man and he won't stop talking. So we have to be very mindful, I think, in our roles as professional clinicians and physicians in the setting, to be more observant, probably hear more and speak less, give an opportunity, I think, for young adolescent males to find a safe space when they're with us or around us, to at the time when they're comfortable and ready to address the issues that I think are substantially bothering them. And very often I hope we'll get away from what we very often have in society, which is an over response to superficial actions. whether somebody, how they do it in school, or if they're having a fight, or if they're having some behavioral difficulty. First of all, we have to dig to get to the root of the problem. Very often, that is an issue. Very often, it's a sociological conflict at home or at school or with family or friends. If we don't hear about that and find ways to strategize to address it, we're going to continue to have many of the behavioral manifestations that also get young African males in a variety of trouble. I'd also argue that on the gun violence issue you mentioned earlier, I've spent 3 years writing this gun violence book, and really 3 huge take-home messages. One, first and foremost, people very often want to have a gun because they feel weak and afraid and powerless. The gun, very often, whether they use it or not, makes them feel strong and powerful and norm compared to everybody else. We can address that in psychiatry through more effective therapy and interventions. Secondly, though, I think all too often individuals don't appreciate the magnitude of a gun. I had a person in my career once before, one of my patients, was really a forensic case, not really a patient, who stated after being shot during an evaluation, "Hey, doc, if I'd known it's going to hurt this much to get shot, I would have been in a gang banging, things of that nature." So very often, many have what I call a Bugs Bunny approach to the real world, thinking that you shoot somebody today and next Saturday they're going to be on TV again. Not really the case. So we have to, I think, be mindful to bring, I think, a qualitative realness and authenticity to, I think, the high level risk persons are engaged in. And the final point is we have to find a way to give them a safe space to talk to us in a way that perhaps they can't talk to anybody else because of all the machismo that often, I think, blocks, I think, communication with young African males.
Dr. Bailey, you bring up an excellent point that all therapy is not necessarily good therapy. And that just because you're sitting and talking to somebody doesn't mean that person you're talking to is going to be effective for you. And I think all of us as Black men in the world have felt that mismatch between us and the person that was supposed to be helping us. So Dr. James, can you talk a little bit about, as a patient looking for a provider, how do you know when it's not a love connection, if you will? Or how do you know it's not a connection with that provider and you should seek another alternative or another opinion?
We don't like to talk about that kind of thing. But when you're looking for a therapist, the first session should be like a first date. Let me ask you some questions. You ask me some questions. If we feel like at the end of the hour, this was a good session, okay, we can do work. If it doesn't feel like it was a good first date, then you need to start shopping for a therapist. Just because that's who's on your insurance list does not mean that is going to be a good therapist. You need someone who's really open to creating a safe and a brave space for you to be vulnerable. For a lot of us in the way we are trained as clinicians is to be diagnosticians and follow the criteria. If you don't fit the criteria, then we don't, they don't fit. We don't know what to call you. We don't know what to call it. So it doesn't fit. So we don't deal with you. As I have become a seasoned therapist, I'm like, okay, throw the book out. We'll figure that out at the end. You're here for a need. Let's figure out what the need is, what the trauma has been. Dispel all the myths about being in the room with somebody. You're here for help because you hurt. Let's just figure out a way to stop the hurt.
Excellent.
And that's a good way to start.
I want to, Dr. Fisher, I have a question for you. I want to hold it just for a second and go to Dr. Lawson. Dr. Lawson, can you amplify that about how can patients find a good match to get help for PTSD? How can men understand when they've made that connection with a treating provider?
Yeah, I think many of the points that were just made are extremely important, but a lot of it can be seen by the extent to which there's a key interaction. One is the provider engaged and actually listening to the person. Two is whether or not the provider is culturally aware of the circumstances that's going on. I've been very interested in the problem of misdiagnosis and overdiagnosis of PTSD. When the person talks about flashback experiences and others, and the provider says, well, that sounds like schizophrenia. Or when the person talks to them about some of the personal experiences they have, and the provider sort of eyes glaze over because he can't comprehend the kind of experiences that the person has faced. Many of the folks in our community have actually seen some horrendous and life terminating events, but the provider themselves may not appreciate it. Again, the lady I mentioned who was sitting in a ventilator with COVID could not get her family to appreciate or understand how it was to be in a ventilator that long or to have a life-threatening illness, and could not get providers to really appreciate how she was feeling. And so many times folks with PTSD end up suffering in silence, going through the turmoil, inner turmoil, because the provider cannot link to them the kind of experiences that's going on. So making that connection and being able for the provider to be able to have some empathy is extremely important. You don't have to have lived experiences, but it's important to be able to appreciate lived experiences.
Excellent. Those are excellent points. Dr. Fisher, when you approach this from the occupational medicine standpoint and you're trying to say, maybe I'm not going to be the treating provider, but I see someone that needs help, how do you identify resources to refer them to that you think will be quality referrals rather than just a referral?
Oh, excellent. We, it's been said before that we don't have a health system, we have a disease system. And so often I have to understand what kind of health coverage my clients have. And many times, they struggle within their own health networks to find the specialty clinic care that they need. And I find myself time and time again as an occupational health physician, working with people to try and find an appropriate place for them, within their system or within their budget. So, but that having been said, once the diagnosis has been made, it's a matter of getting the mental health referral, whether that's with a mid-level provider or licensed clinical social worker, or clinical psychologist or psychiatrist. And so, I have to explain the different options and different types of providers, or just their primary care, doctor, if they're comfortable within that scope of care.
I think that's a wonderful perspective, because I love how Dr. James really talked about what you should look for as a patient, and Dr. Lawson sort of filled that in with more about what an actual real connection looks like. And then Dr. Fisher, you came in with like, well, as the person doing the referring out, this is what I'm looking for to try to facilitate a good connection. Dr. Bailey, can you talk a little bit about that differential diagnosis that Dr. Lawson brought up? What can PTSD be confused with? Or what can be misdiagnosed when it really is PTSD?
Well, I thank you very much. I think many of us have read quite a bit about this over the years. There's nobody better than Bill Lawson to talk about it. He mentioned it earlier. I think on his panel, maybe the person who published the most on this idea of the misdiagnosis of the African American person. And disproportionately, I think we all are very much aware that the diagnosis that African Americans have received over the years have often been wrongful, because been more focused on them being psychotic versus having a mood or non-psychotic disorder. In old days, we called it being more psychotic than being neurotic. And all of them much more likely to receive diagnosis within the sphere of violence. Antisocial personality disorder is a classic one that I, as a forensic trained psychiatrist, often have seen as a misdiagnosis of an African American person, especially a younger person, especially a male person, a young adult or male person. I think that the reasons are threefold. First and foremost, if there's fear by the provider in the diagnosing of somebody sitting in front of them, like there's fear by law enforcement, for example, in those settings as well, often they are unable to look through, I think, a fair, open lens in who they're assessing, and they overread or misread cues in an adverse type fashion. They think that a person like myself is talking loud in a violent way. I probably talk loud because that's what people talk in Beaumont, Texas. But I hope that you don't perceive that I'm angry or agitated in any form or fashion, although my voice is not particularly low. In addition, I think they also see a misdiagnosis all too often because persons, I think, are in an attempt to quickly end the conversation. Very often, when you really are engaged with a patient and there's a good therapeutic alliance is developed, it takes more. That's why doctors in our profession want more time, not less. We want to consider a full differential. There could be a variety of issues in play. You don't just quickly overreact and overrespond and jump to the easiest item. One symptom that could be related to psychosis, like paranoia, chronic schizophrenia, and the deal is over. Very often, I think, overzealous attempt to give short shrift to a person who you don't value as much, because particularly of their race or their lower SES status, leads to such misdiagnosis. I think a third and final point, and maybe even more as well, but I think a third point, big one, is the idea that we are already thinking about what the results will be. How do we treat it? How do we address it? In schools, increasingly now, if you give somebody a DOC type diagnosis, I call it, Department of Correction, then the police come, the authorities come, and they go to alternative school and maybe go to jail in some form or fashion, as compared if they get a DMH or Department of Mental Health type diagnosis, major depressive disorder or an anxiety disorder or oppositional defiant disorder or ADHD, then they're going to see a professional, a psychologist or a psychiatrist. They're going to get clinical treatment, medications, and they're going to get ongoing therapy. And I would add a fourth one. Early in my career, we used this term a lot more than we do now, but I think it still resonates. This idea that some providers think that certain individuals, I think, again, unfortunately, adversely, the misunderstanding of African Americans is that they're not what's called psychologically minded. The idea that we can make a very quick decision or determination based on our misunderstanding of what their IQ may be, without doing an actual WAST test, that they're not going to be able to benefit from clinical treatment or clinical therapy. I mean, there's the great forms of therapy that you actually already heard other panelists mention tonight. So because of that, we moved to, I think, the least common denominator, a psychotic diagnosis, because the concept is, since you're not psychologically minded, you wouldn't particularly benefit from the more engaged and therapeutic forms of talk therapy that we have to offer. All four of those, I think, were key issues and reasons for misdiagnosis of the African American.
What's really interesting, to boil down what Dr. Bailey is saying, is basically they're making a decision that you're too slow and uninsightful to be able to benefit from talk therapy. And I think that's an easier and a cheap way to push people towards correction rather than support and wellness. And I think that's a phenomenal point when you talk about the school to prison pipeline. That's a phenomenal point when you talk about the over incarceration of Black men specifically. That's a phenomenal point when you talk about how Black men specifically, and Black women as well, are problematized for typical behaviors. Dr. James, can you tell me an intervention everybody can do listening to this to help people move towards the medical side of the spectrum rather than the criminal justice side of the spectrum when dealing with PTSD type issues?
Okay. Being from the VA system, they have heavy emphasis on a brand of treatment they call evidence-based practices. The evidence-based practices are usually anywhere from 10 to 12 sessions. You cannot tell me if you've had a lifetime of PTSD, depression, anxiety issues, just life trauma, problems with living, that you're going to resolve those things in 10 to 12 sessions. But if that's all you get, then you open up a can of worms and then you drop people because your sessions are up. A long-term open-ended therapy is not as in vogue because it can be expensive. But if we're talking about how do we get people in, we have to get people in and help them, honor them, make them feel good about being there. And if you tell them, oh, we only have 12 of these, let's get it done, you're not going to get to the essence of a lot of what is going on with people. Also, whatever that treatment is, it needs to be culturally competent. Whoever's delivering that therapy has to understand the population that they're dealing with. Here in New Orleans, in our mental health division, it is primarily white female therapists. I have to bring this to people's attention all the time because in the luxury of being a home-based primary care psychologist, and I deal with people that are of geriatrics, age anybody over 65, not to offend anybody if you're 65, but a more geriatric population. These men are not going to sit in a room and talk to young white women about the vulnerabilities of their lives. I go into the room, they see a person that looks like them, hopefully is sensitive to their issues. We start talking about depression, marital discord, then we get into sexual dysfunction. No Southern Black man is going to sit in a room with a young white woman and talk about his sex life. So the therapist has to be sensitive enough to what is going on in the room to not just brush off a diagnosis because I'm not comfortable with the area, and really meet the needs of the people coming in for the treatment.
Excellent. Dr. Fisher, what do you have to add to that?
That was excellent, Dr. James. Points very well taken. Again, getting back to community mental health, healthy interpersonal relationships. So we're talking about things kind of downstream, in the office place. But from my perspective, building healthy workplaces. So employee wellness programs, letting people know that helping people overcome the stigma of their condition, so that if they feel comfortable talking about with their workplace supervisors, if they need a workplace accommodation granted, in accordance with the Department of Labor guidelines. Okay, if a workplace accommodation can be granted to modify their workplace to make them feel more comfortable, and making happier workplaces to avoid problems. So focusing really on employee wellness, happiness, warm and fuzzy things like that, and clinical preventive services. How can we prevent exacerbating the problem?
Excellent, excellent, excellent. Dr. Lawson, I'm gonna come back to you in just a second. I want to get Dr. Bailey in on this. One of the things that you're going to be taking over as a department head at LSU is you're going to be supervising a diverse workforce. How do you communicate to a non-Black male clinician that has to support Black men of varying ages, how to connect with them in a way that empowers that person to not be the situation Dr. James just talked about, where there isn't going to be a Black man of a certain age anywhere that's going to feel comfortable bringing up their sex life to a young white woman in that sort of setting?
Well, I think it's an austere point. I really appreciate your comment. I hope I will find a more diverse, trained workforce. I think in many settings, our workforces mirror much of the dichotomy of the difference, I think, throughout America. And that's actually been part of the problem, I think, with healthcare. We need more variability, diversity of more of a broad base, people of all different races and ethnicities, language, and cultures. I think Dr. James' point was very, very clear. For some persons, when they walk in a room with you, they can't decide to get comfortable enough for you to develop the therapeutic alliance needed to provide good quality care, because society has a culture with them to think that issues such as race and gender and age matter a great deal. So we keep sending them to somebody who's on their panel who may have a different race and gender and age and culture and background and religion that may be a no-go for them for a start. So it's my responsibility to really make this point as articulate as you just made it, to all the persons who work for LSU and otherwise, that it's our responsibility, not the patient's responsibility, to develop a good therapeutic alliance may mean partnering with another positive clinician who meets some of the areas, I think, of value that patient may need. I've often said throughout my career, there's often been the value of what they call a sidewalk consult in medicine. Somebody might call me the psychiatrist when the patient didn't feel like they needed a full psychiatric consult. They want a nephrology service or a different service or what have you. But the other doctor thought that you could offer something different because you're training as a psychiatrist. You do the sidewalk consult. Exactly the same, very often based on your race and your ethnicity and your cultural background and the sensitivities that I think are inherent. Again, I think that James made a tremendous point when he said, not only is that African-American man going to walk in and talk to him because he sees his race is clear, but it's probably how they engage in those first few minutes of therapy that's going to allow the balance that's required for the patient to feel comfortable and then to emote and to elaborate kind of how he feels. Remarkably important, and the kind of things that I think you should be culturally sensitive to appreciate. Now, I don't think that you have to be the same race to be culturally sensitive. Some persons can do it across cultural or racial ethnic lines, but the reality is all too often that doesn't happen. And that's what leads, I think, very often to the disparagement of patients who are of a different race in this type setting, and disproportionately African-American males, because of the machismo, I think, of being male for all males throughout our country. And the issue, I think, I've been from the South, I'm from Beaumont, Texas myself. There's some additional, I think, barriers in that regard. There's a lot in play that makes that issue very, very difficult in these settings. So it's our responsibility, not that of the patient, to make that alliance occur, make it happen normally. It's my job in his new role as chair to make that argument as effective as I can to the LSU faculty.
You know, I'm going to come back to you, Dr. James, because a lot of people have referenced your very, very salient example there. But Dr. Lawson, how do you empower your colleagues to be better clinicians and professionals for our Black men suffering with PTSD?
I think that's an excellent question. One of the things that I've found is that many times we assume that the problem with many folks is that they are that way because of racist attitudes and so forth. I really understand the appreciation as we move towards the whole idea of institutional racism. And that is that in many ways, folks do in fact have the capacity to be able to transcend these issues, but that because of the institution that has been created, they find that it's in their interest to be able to function in a way that is oppressive to people of color. And at the same time, many people of color learn very quickly that if they're going to be successful, if they're going to be effective, that they themselves have to adopt those kinds of negative attitudes that you see in the larger society. So I've many times have residents who adopted concepts that, frankly, racist, even though they're people of color, they found that if they're going to be survivors, what they have to do is to develop demeaning, oppressive attitudes towards the patients themselves and to not give them the kind of concern they had. So part of this empowerment is to help them to see that it's in all of our interests to treat people as human beings, and we can try to transcend the immediate institutional oppression that is found for all of us.
Good. Dr. James.
I was just going to say, you were asked, Dr. Bailey was talking about dealing with residents and training. One of the things that we just started this year at the VA, that my chief of psychology has appointed me to be the co-training director with DEI emphasis, diversity, equity, and inclusion emphasis. And my role is to sit on every one of our training meetings, our case conceptualizations, to talk to residents and our trainees about what are the other aspects of this person from a diversity, equity, inclusion point of view were considered, not considered, why not, and what do you need to learn going forward? And so my job now is to not just deal with, sit back and say, okay, this is a problem, to be a part of the fix of if people need to be trained differently when it comes to cultural issues, then we need to be at the table to make sure that that happens.
Excellent.
And so I wanted to make the point that the way we get to people is not just say, read a book. Let's talk about real live cases and what's failing, what's not, what's successful, what's failing. Because a lot of times African Americans are seen as being poor patients and their compliance rates are high. Why are those compliance rates high? It's not a point of psychological mindedness of the patient. It's more about the engagement of the person in the process.
Mm-hmm. Excellent. Dr. Fisher, you talked a little bit about making work environments that are affirming and work environments that are supportive and non-hostile to sort of also address PTSD and make people healthy, more wise, and more comfortable in these settings. What are some things that you see from your perspective that can be done to make sure these sort of culturally competent ways of identifying PTSD and supporting people suffering through PTSD in a work environment? How can that be done with people that are charged with looking and monitoring those environments?
Right. So employee wellness programs do the sort of things like promote exercise and allow their employees to get outside and walk and see some sunlight and develop healthy interpersonal workplace connections. Things to design a happier workplace. But also, when I mentioned clinical preventive services, those are screening services and counseling services and educational services. So providing employees with educational information that if they have problems, then this is where a safe place that they can go to get help, or counselors for larger designated counselors, for larger employers may have, that could provide lower level counseling services to help people get the care that they need. Now, the other discussants, Dr. Bailey, Dr. James, Dr. Lawson, mentioned that, the importance of the therapeutic alliance, a therapeutic rapport, a relationship that one has with whomever they're talking to, and if that person doesn't understand their community, that you say the African American context or structural racism or violence and so forth, then they may then that clinician may miss what's going on, right? So in the context of the workplace, they may just see, oh, this person has a gambling problem or an eating disorder, obesity. Obesity's become a big issue in the workplace, or a sex disorder, or an alcohol problem, right? So these are problems with mood-enhancing substances, right? And so, and the focus may be just on the substance use disorder or alcohol use disorder, and we may miss the stress disorder, right? And I'm not denying that the person has a problem with some mood-enhancing things and substances, and needs help for a gambling problem or a sex disorder or a eating disorder or an alcohol use disorder, but screen for the stress disorder and concomitantly address that. And
excellent. Dr. Lawson, in these times of COVID, are we seeing an increase in PTSD? And the reason I think that's relevant for us in New Orleans, when someone dies, we have our rituals to grieve and honor them. Those were taken away through the process of public health to control the spread of disease. So people were suffering and didn't have a way to even process it that was typical. Do you think that's making the prevalence of PTSD in these times of COVID higher in Black men?
I think you just hit upon a very, very important point that we sometimes tend to forget. And that is that we talk about PTSD, we talk about stress, we talk about the other problems that we're facing now. But our ancestors, all the way from the time of slavery to the oppression that otherwise had developed strategies to survive and to continue to flourish. Thus, we have the ceremony associated with funerals. We have the support that our community can provide even when our resources are limited. We've developed strategies to have families provide ongoing support from the community as a whole when we lose the people that have served as the mentors and the leaders of the community. COVID has then reintroduced these kinds of traumas. And as a result, I think it's important to recognize that during this process, we may have to go back and look at what has been able to enable the community to survive. And that is the ceremonies around the funeral. The family is coming together as a whole rather than as individuals. Looking for, at spiritual events rather than materialistic things as a foundation for going forth. Yes, there has been an increase in terms of post-traumatic stress disorder. I've seen an increase in terms of attentional deficit disorder, a whole host of things that has emerged as a result of COVID. And it's not just the direct effect of the virus itself, it's also the sociological impact and the loss of key elements in our community that has led us to be able to try to find other ways to deal with the ongoing stresses. Some folks have, as already mentioned, that they may have to use self-medication, violence, other kinds of ways that are not supportive in terms of survival of the community. But we recognize that these kinds of ongoing issues are not a key part of this whole process, but also we need to see how we can be creative. I like to always look at the analogy of the when you have an eggs break, let's make some scrambled eggs.
Yes.
that we need to become creative. The whole emphasis on a virtual environment to be able to provide services and support. The importance of terms of looking at community efforts in terms of bringing food and support to each other, removing some of the barriers that have emerged in more supportive times to go out and check out your neighbor and see what's going on. We need to be able to redevelop those strategies that has helped us in the past, because this problem of COVID, some say will just pass. Well, it ain't passing. We're looking at a long haul syndrome. We're looking at ongoing issues, ongoing problems, as both community as well as individual based, as we struggle to emerge from this situation.
You know, Dr. Bailey, can you talk a little bit about how grief is impacting PTSD? Because we had over 500,000 people die in COVID. Those are people that were loved. Those are people that were somebody's mama, cousin, brother, auntie, best friend. And we are now processing that grief without some of the touchstones Dr. Lawson talked about of real people coming by to check on you, or the ceremonies that Dr. James is referencing in New Orleans about our second line culture and our ways that we celebrate and elevate and honor our dead. How is grief playing into this, Dr. Bailey?
Well, I think it plays a big role. I think that probably no place more so than New Orleans gets the attention, I think, in our country for handling grief differently than other cultures or other locations, but in a way that is necessary for those who live on after the death of a loved one to be able to survive emotionally as well as surviving physically. I think that grief is a normative process. We use the definition bereavement in psychiatric medicine to imply that you can have grief normal for up to 6 months after the death of a close relative. You don't get a diagnosis then. If it's more than 6 months, then it becomes abnormal, because your body's on and your brain's on normative defense mechanisms should have been able to kind of get your self psychologically back on track after the amount of time period. If you're blocked or blunted from being able to manage a normative grief process, if you can't go to the hospital to see a relative who may be at risk of dying due to COVID-19, if you can't go to a funeral. I had a discussion with a pretty prominent African funeral director in Virginia, stating that the number of deaths of Black funeral home directors has been so high during this whole COVID process. We haven't been aware of it, but it's actually had a substantial downward impact, I think, on many families. If the funeral home directors, are not able to work or closing down, imagine the fear that actually plays, I think, in many others. So I think that you make a very good point. Grief is essential to the normative healing process psychologically that all persons must go through. The variety of cultural mores that are in play, the time that it takes to have a funeral. I was an altar boy as a Catholic early in my career, in my life. These funerals happen very quickly. Now they're longer and longer, sometimes 2 or 3 weeks out, sometimes a month out. Is the actual grief process as well. All of that, I think, plays a role in giving those who live a chance to kind of get back on track and move forward in an effective way. I'm very concerned with many of my patients and the like, that if they don't go through a normative grieving process, there's substantial adverse implications on their mental health going forward.
Excellent, excellent. Well, we're coming up on the hour here, and this has been a wonderful conversation. The comments that have come in across the chat board have been phenomenal and shows our audience is really engaged. As each of you give a chance to say goodnight to the audience following us here on Facebook, I'd like you to do 2 things. Number 1, leave us with a nugget you want everybody to keep in their pocket after this conversation is over. And number 2, if somebody wants to talk to you on social media, how do they find you? All right. So what nugget you want people to take with them? And number 2, how do they find you? Dr. James?
What I want people to know that being vulnerable is not a weakness. It is a strength. To recognize when you hurt, if you cut yourself, if you put a Band-Aid on it, if you have experienced any sort of trauma that has caused you any sort of distress, seek someone out to help you deal with that you don't carry that internal scar over and over. And I think Dr. Scholes has my email address, my Empower NOLA email address, that they can put that on the screen for people if they want to get in contact with me. I used to answer questions within 24 to 48 hours.
Very, very good. Thank you, Dr. James. We appreciate your wise words and your participation today. Dr. Fisher, what's the nugget you want people to take with them, and how do people find you after this is over?
I think overcoming stigma is the all-important thing that the RAND Corporation, the Institute of Medicine, National Academies publications have all focused on, stigma. So as long as things that we can do to kind of dispel, stop pathologizing, stress disorders and allowing people to come forward. I'm easy to find. I'm one of 2 full-time physicians at the Smithsonian Institution. Our secretary, Dr. Lonnie Bunch, is and our curators are designing programming and events to help address community mental health concerns. So it's a very, very important issue that is recognized by the Smithsonian. Excellent.
Dr. Lawson.
I think that it's very important to remember that we've survived thus far. We sometimes downplayed some of those survival techniques, but one of the important ones is that we're flexible. We'll be able to look at new situations and develop creative ways of doing it. And we have the brain power, the intellectual, the emotional power to be able to continuing to move forward. I mentioned the making sure you can deal with the scrambled eggs, but also we should get rid of this idea that it's better to be bad than mad. That we should recognize that if you're in distress, you don't have to go out and become involved in terms of self-destructive ways, but look at it as strategies that work to bring people together to be able to function in an effective way. Email is wlawsonpsy@gmail.com. I will respond, although not immediately. And
thank you.
Because I'm semi-retired, but I will eventually respond. And I provide clinical services through MD Live, which is a virtual, nationwide virtual program, and also Emerson's clinical trial group, which we develop new treatments in terms of individuals needing new and innovative approaches.
Thank you. Dr. Bailey, bring us home. What's the nugget you want everybody to take with them, and how do they find you after this?
Very briefly, I think that the term resilience was stated earlier, perhaps by Dr. Fisher or others, and I think it's a very timely point. We as psychiatrists and as psychologists, as mental health professionals in our community want our patients to be able to survive, to thrive in their own lives and own livelihood. In doing so, they have to be able to get past and handle and address stressors, especially overwhelming stressors that can lead to diagnoses like PTSD. So whatever we can do to help them build emotional and psychological strength and capacity to resolve those concerns builds what we call the capacity of resilience. And I support it, and I think that we encourage persons to go for care and get into care with someone who you have a good therapeutic alliance with, and it will help you. I brought all these numbers. I think my Twitter handle is @Ron Bailey, and Ron is spelled R-A-H-N, my father's idea. Bailey's B-A-I-L-E-Y. My Instagram is @Ron-K-Bailey, MD. And my website is www.baileypsych, BAILEYPSYCH.com. But feel free to email me. I, like Lawson, will respond as quick as I can. But it's one way that people feel comfortable addressing those concerns. And my email is Ron K. Bailey, MD, RAHNKBAILEY, MD, @Comcast.net. Finally, I'm brand new, as the show pointed out, at LSU. I encourage persons to see LSU as the arbiter of good quality care that it should be and can be in our community. Our number is 504-568-6004. I'll repeat it, 504-568-6004. And one of our 127 doctors will try to take care of you. Have a good evening.
Well, with that, Dr. James,
Bravo.
Dr. Fisher, Dr. Lawson, Dr. Bailey, thank you for your time. Everybody listening, remember, being vulnerable is not a weakness. Number two, overcoming stigma and stop pathologizing stress disorders. We've survived thus far, and we have the ability to cope and go further, to survive, thrive, and build psychiatric strength and opportunity. Those are the takeaways. I appreciate you listening to NMA Talks for this June, focusing on men's health and PTSD. Join us at the NMA National Convention on Saturday, July 17th to the 21st. My name is Dr. Maurice Scholes, and you can reach me at Doc Mosho, DOCMOSHO, on all platforms, and I'll get back at you as soon as I hear from you. Thank you very much, and good night, guys.
Good night.